Well, it seems like spring is finally here, at least in the D.C., Northern Virginia area, and I'm so glad that you all are able to join us today for our treatment options education call. I know this is a topic that has been most popular in our regional meetings that we hosted throughout the U.S., and I'm glad you were able to join to hopefully answer any questions you may have about what your treatment options are as an ESID patient, or get any further clarification of those options, because there are more than I guess one would expect. So Joanne, if you're ready, feel free to take it away.
Okay. Hi, everybody. Welcome. I'm glad to see that there's so much interest in treatment options. I actually am the DPC Education Manager, but I also educate patients in northern Delaware that have chronic kidney disease on what their treatment options are. So let's get started. So the objectives are to raise awareness and understanding of kidney disease and the available treatment options. Like I said earlier, it's really amazing that there are still people that actually dialyze in clinics that have no idea that they can dialyze at home. So hopefully we'll be able to get that word out and let people really make the decisions that they want to make in order to live the life that they want to live. So that's to empower the patients and help them learn how they can take an active role in their own care by learning all they can about kidney disease and their options. All right, so the treatment options that are available for end-stage renal disease, as we all know, are hemodialysis and peritoneal dialysis, transplant, and no treatment. So hemodialysis, there's several types of hemodialysis. Typically, hemodialysis is done in a clinic with trained staff. There's also home hemodialysis, and there's several ways to do that as well. And we're going to talk about vascular access, a very important part of treatment options. For peritoneal dialysis, there are two types or two ways to do peritoneal dialysis, one being CAPD, which is continuous ambulatory peritoneal dialysis, which is actually a manual way of doing dialysis. And we also have CCPD, which is continuous cycling peritoneal dialysis. And the catheter access involved with peritoneal dialysis we'll talk about as well. Transplant, as we know, is considered the golden option. It is not a cure, but it is simply another option for kidney disease. And then there's the option of no treatment, with dietary, social work, and a financial coordinator involved with that. So we're going to talk about in-center hemodialysis, the pros and cons, kind of, if you will. So for the pros, the dialysis is performed by trained professionals. There is socialization aspect of in-center hemodialysis, meaning that there are other people that know the life you're living. They are also sitting in those chairs. They know the diet. They know the routine. There's only 3 treatments per week, and you have 4 days off, if you will. You don't require any equipment in your home, and there's medical help available if there's an emergency, and that is if you're in-center dialysis. So the socialization aspect, there are patients who can share similar experiences when you're new to the clinic. You know, it can be pretty scary to go into a dialysis clinic with everything going on. It's a very busy place. And if you would get a buddy to kind of tell you what their perspective or their experience has been, it could be helpful. Patients usually spend their time either sleeping, watching TV, and in some dialysis facilities they can participate in educational programs with their flat screen TVs. The disadvantages for in-center dialysis would be traveling to the clinic 3 times a week. So that's snow, rain, if you don't feel great or whatever, you're still required to travel to the clinic. And then there are wait times. You know, you have to wait until your scheduled time to be put on to the dialysis treatment. And then after the treatment, there's bleeding time for the hemostasis. And then if you take transportation, there's wait time for that as well. You do need a permanent vascular access, and we'll get into more detail about that. With the vascular access, 2 needles are inserted into the vascular access every treatment. you are on a fluid restriction and dietary intake depending on your urine output. And there's possible discomfort like headache, nausea, leg cramps, and tiredness. I want to talk a little bit more, though, about the hemodialysis access. So for blood to flow through the dialysis machine, you need to have an access to enter into the bloodstream. So you would consider that access to be your lifeline. It's a way to reach and clean your blood. So there's 3 access types for hemodialysis, and they are a fistula, a graft, or a catheter. Fistula access is considered the best access choice for hemodialysis. It's a natural access because it actually is your vein and artery surgically connected. It has the lowest chance of infection. What happens is the surgeon connects one of your arteries to a vein under your skin. The surgery is commonly done in an outpatient operating room. Then the fistula access should be placed for about 6 months to a year before you begin your dialysis if possible, to allow time for that fistula to heal and develop or mature. So your surgeon or your nephrologist will provide direction on the recommended timing of fistula placement. But very important to remember as you think about treatment options that if you have that fistula placed for hemodialysis and you decide that you want to do peritoneal dialysis, or even if you get transplanted before the need for dialysis, that access will always be there. It doesn't harm your body. It's kind of like an insurance policy, so that if, say, the transplant did not work or peritoneal dialysis, you changed your mind after you started, you would always have that access there, and you would get good dialysis going on to hemodialysis from any other option. So like we said, during the treatment, 2 needles are placed in the fistula, and then these needles are connected to the dialysis machine tubing so you can receive hemodialysis. Some people have very thin or hardened arteries and veins, so they're unable to get a fistula placed. So the second best type of access for hemodialysis would be considered a graft access. So a graft access is actually a piece of rubber tubing surgically connected just as you would with the fistula. So the tubing is surgically connected to an artery and a vein, performed in an outpatient operating room, and a lot of times the graft can be used several weeks after the graft surgery. Same idea though, you use the 2 needles that connect to the dialysis tubing. The third type of access, which we really don't like to see used, is really only to be used in emergency or emergent cases. So that would be the catheter. We call that a hemocatheter or a CVC. And what it is, it's a long piece of plastic tubing that's shaped like a Y. It's placed in your neck, chest, or groin, and it connects to a central vein. And then the other end of the tubing is outside the skin, and this is how you hook up the dialysis tubing to that. Most catheters, hopefully, though, are temporary and used only until a graft or fistula is ready. The hemocatheter is considered the poorest option and should be avoided, if possible, because of very high risk of clotting, a high risk of infection, and because it can actually slow down the blood flow rate during your dialysis treatment. However, there may be conditions that prevent a patient from having a fistula or a graft. For example, like I said earlier, if you have blood vessels that are not strong enough for a fistula graft, then a catheter may be used. So now we're going to talk about peritoneal dialysis. So the peritoneum, everybody has a peritoneum, and right now it's kind of a sac that kind of just protects the organs and vasculature from under your breastbone all the way down into your groin area. So what we do with it is like a filter. It's a natural filter for the body, and a catheter is placed into the abdomen. After that catheter is healed up, typically 2 weeks, in some cases it could be used even sooner, we introduce a dialysis solution into the abdomen through this catheter. The dialysis solution actually has dextrose in the solution, and there's 3 different strengths of the dextrose. So what the dextrose does actually is just pull the fluid. So any excess fluid or ultrafiltrate is pulled with that dialysate or the dextrose dialysate. The solution is a sterile solution. So when you put a sterile solution into an area where you can imagine there's toxins that are filled with your blood, the toxins then are pulled into this clean, sterile solution, and that's how the dialysis occurs. So it's a very gentle, gradual way to do dialysis. It's a more natural process for the body as compared to hemodialysis, which is done in a shorter, quicker period of time. It is done daily, though, because, like I said, it is gentler and slower. In particular, for patients that have any type of cardiac issues, peritoneal dialysis is generally recommended by the physicians, unless there's some sort of issue in the bowels or in the area where the peritoneum is, and then sometimes it may be contraindicated for a patient to do peritoneal dialysis. So CAPD is continuous ambulatory peritoneal dialysis. So you can see this gentleman on the boat, right? He's doing his dialysis, and you pretty much can do the type of dialysis anywhere. It has to be a clean area, and when we say clean, it's not sterile, but it has to be a clean area. You don't need a machine or any kind of electricity for this type of dialysis. And typically, when we train a patient to do peritoneal dialysis, we train them also to do manual and cycler if they prefer to be on the cycler. The reason being is the cycler actually is a machine that plugs in, and so if the machine breaks down or if you would have a power failure, then you would still have the option to do manual exchanges. Because like I said previously, PD needs to be done 7 days a week. So when you do the manual form of PD, we mostly recommend patients do 4 exchanges a day. So an exchange is when you drain out the old fluid that has the toxins and excess fluid in there and fill up with fresh solution. You put a new cap on, and then you discard the old fluid and the materials that you use to put in with the fresh solution. What happens then is you go into a dwell phase, then you can go about your business if you work. We actually have some long-haul truck drivers that use this type of dialysis, so they're able to do an exchange before they leave in the morning. While they're driving, their solution is dwelling, or they're actually dialyzing. At their first stop, they'll do their next exchange. We recommend 4 to 6 hours between exchanges. So what they'll do is they will put a mask on, because more bacteria comes from our noses and mouths. We're protected right now because we have skin, but if you have a catheter, whenever you open that catheter, you're exposing the inside of your body to whatever's on the outside. So like I said, the bacteria simply from your nose and mouth would be enough for you to get an infection. So we have all of our patients wear a mask when they're opening the end of that catheter, and just do good hand washing. So no gloves, but just really good hand washing. They make their connections. We teach them what they can touch, what they can't touch. But simply, as soon as they make that connection, they turn the dial, and through gravity, the solution will drain from the peritoneal cavity into a drain bag, which is lower, probably on the floor. And then the fill bag, after you're drained out, you'll fill with this fresh solution and put a new cap on. So we tell our patients probably morning, noontime, afternoon, and then before you go to bed is when you would do a CAPD exchange. 7 days a week, same thing. No partner is needed. There's no real risk. There's no blood exposure. There's no needles. The risks, though, are infection. If you don't follow the procedure as instructed, there's a very high possibility that you will get an infection. And one of the things we tell people every time you drain out is that you want to look at your drain bag and make sure that it's not cloudy. And even if you have to take a second look because you're not sure, we want you to call your PD nurse right away and say, you know, even if you're not symptomatic, we still want to say, hey, you know, I might have a cloudy bag, because cloudy bag is a sign of infection. And if you can get an infection treated within the first 2 hours, more than likely you'll be able to heal up completely from that infection. So really important to check that drain fluid, make sure it's not cloudy. And we also tell people, you know, if everyone else in the house is sick, you're not sick at all, but you start having some symptoms, we want you to call the PD and assume that you have peritonitis. We would much rather treat someone for peritonitis and send it to culture and have it come back clean than have somebody have peritonitis for hours or days, because ultimately peritonitis is a very, very serious infection, and serious infections can actually lead to death. So, so with peritonitis, we want to make sure that you're treated right away, but there are ways to prevent peritonitis. So you wear a mask, you do good hand washing. Another thing to keep in mind is the area that we're talking about where peritoneal dialysis occurs, the bowels are in this area. So we really encourage our patient to have at least a daily bowel movement, to take stool softeners, and if they're having a problem with any type of constipation, to give us a call and we'll get them a laxative or whatever they need, because the bowels can get in the way and cause problems with draining or filling, and actually could even cause peritonitis as well. So one of the great things about CAPD or any type of PD, it's very easy to travel. You actually, if you're on the cycler, would take a cycler with you. If you're on CAPD, you could just bring a couple cases of the solution with you, or you can even have your dialysis provider send out the supplies wherever it is that you're going to be. We have a lot of people that go on cruises, and it's actually no problem at all. So for CCPD, that's continuous cycling peritoneal dialysis, you can see there's a cycler. It's about the size of an old VCR. It has tubing. You can see in that bottom picture there. There's several different lines of tubing. There's a tube that connects to the solution. There's a tube that actually connects to your catheter. So what you do is you set your machine up, and you can actually set your machine up anytime during the day, and just leave it sit there until you're ready to use it. Then you come in at night, put your mask on, do your good hand washing, and then make your connections, and then you will get onto the machine. Like I said, same thing with the cycler, though. You're going to check the drain fluid first, because the first thing that happens, you start draining. You'll check your drain fluid, make sure your fluid's not cloudy, and as long as everything's fine, you just get yourself in bed and relax. You don't feel the fluid coming or going, and you actually, there's a couple of options for draining. You can drain right to the toilet, so that helps in the morning with not having to empty bags. If your bathroom is far from your bedroom now, you can actually have an opportunity to drain into drain bags. And so the downside of draining into drain bags, of course, is that you would have to empty them out in the morning before you discarded them. So everything is a new, fresh setup every evening or every day whenever you're going to set your cycler up. And then you empty out everything and then throw everything away. So there are a lot of supplies involved. Most people get a monthly delivery, and that's probably about 40 or 50 boxes. I would say the size of a walk-in closet probably could fit your supplies. If you can remember earlier, I did say that when you do CCPD, that's the cycler, we also train, the majority of clinics will train you to do CAPD as well. Because it's a nice option. If you want to skip a night on the cycler, you can actually do some manual exchanges in exchange for the cycler at night. Or some people just don't want to be attached to a cycler one night, they're going out or whatever. It just gives you that flexibility. Most people are on the cycler, though, for about between 8 and 10 hours, and that depends on your body and how quickly or slowly you dialyze. And we can do a PET test. It's called a PET test, a peritoneal equilibrium test, and that will tell us how quickly or slowly your body dialyzes, and then that's how your doctor will set up your prescription. So same thing with CAPD. No partner is needed for this type of dialysis, and there's the cycler program is according to the doctor's prescription, and we actually have an IQ drive or a data stick that goes into the cycler, and it actually records all of your exchanges. So it records how much is going in, how much ultrafiltration, and then in the morning at the end of your treatment, there's actually a screen where you can put your vital signs in, your temperature, your weight, and then when you go to your clinic for your clinic visit, you just simply bring this data stick with you, and they can download it and print out your records. Now, when you do CAPD, you would have to do manual record keeping, because you want the clinic to be able to have information, to make sure that everything's going well, that your blood pressures are staying where they need to be, and your weight is as well. Typically, when people do peritoneal dialysis, they're only required to come to the clinic twice a month, so that's a big plus. They come one time and have their labs drawn, their feet checked, their medications checked, or a nursing visit. And then the second time they come, they'll see the nephrologist, the dietitian, the social worker, and the nurse. Most home dialysis clinics have an on-call nurse 24 hours a day, so that's really important that you have that support there all the time. Like I said, the supplies are usually about the size of a walk-in closet you could fit. When you go on vacation, you simply will pack up your cycler and let the customer service people know with supplies where you'll be, and they actually will deliver the supplies to wherever it is you're going to be within the United States. They do some outside the United States, but really check with your travel team before you would make any kind of plans for that. The training for PD usually is about 6 to 10 days. Typically what happens is the procedure is pretty simple. You go in, and if you learn CAPD, you'll do a couple exchanges every time you go into the clinic, but we really try and focus on infection control. We want to avoid any kind of peritonitis or any type of infections with our patients. Also, we focus on dietary needs, so you'll have a dietitian, because with PD, with the drain, actually you lose a lot of protein. So we really encourage our PD patients to kind of, take protein supplements, eat meat, eggs, fish, for those protein meals to really help keep their albumin levels up. Now with PD, like I said, it is 7 days a week, so it is a lot more dialysis than just the 3 days a week in the center. So what ends up happening is the fluid restriction is not near what it is in center, nor is the dietary restriction. For the most part, and I can never say all, you'll always have to refer to your healthcare team, but for the most part, PD patients can eat potassium, so that's oranges, bananas, tomatoes, those type of foods, and that is because they're dialyzing 7 days a week. So that's a big, big perk. Also with PD, people tend to be able to hang on to that residual urine. So in other words, when you do in-center dialysis, sometimes maybe after a year or so, people frequently stop urinating altogether depending on what the cause of their kidney disease was. With PD, we're able to actually hang on to that ability for our patients to have that residual urine, which is real helpful, for that fluid restriction and the fluid buildup. And good for your cardiac status as well. So some of the PD advantages and disadvantages. Advantages that we talk about is patients very involved, right? So it is a lot of responsibility. It is an easy procedure, but it is something that has to be done routinely, and it's every day. You have control over your schedule. If you do CAPD, you can do those 4 exchanges throughout the day at your schedule. If you do the CCPD, same thing. We can set that cycler up where you can do an exchange sometime during the day and then do a shorter exchange at night. I mean, there's a lot of flexibility. More liberal diet, we talked a little bit about that already, and the 2 monthly visits versus the 12 visits to a clinic. More steady physical condition, so patients that dialyze every day, you can imagine their lab values are very stable, their fluids are very stable. It's much better for the heart. There's no needles involved, and you do have the freedom to travel. So there's no setting up at another clinic, no interruption of your vacation because you have to drive to a clinic, you have to be doing your dialysis. You would just simply do your PD as you've done it at home. And it does preserve the blood vessels and allows fistula and grafts time to heal properly. So we're, as time is going on, people are looking more at PD first versus having a catheter put into your chest. So it's an opportunity for a PD catheter to be placed, And for patients to get their dialysis through this catheter while they're having their fistula mature, say that you want to do hemodialysis and you have to crash into dialysis because of no previous warning that you're going to need dialysis, which unfortunately happens a lot. Instead of putting that CBC or that catheter into your chest that has a high rate of infection and tends to clot off, they could put that fistula in, and while that's healing, you could have a PD catheter and have peritoneal dialysis. And like I said earlier, though, you may, if you started on peritoneal dialysis and you did not like it, once that fistula matured, certainly you would be getting great dialysis with using that fistula. The disadvantages of peritoneal dialysis is that it is 4 or 5 exchanges a day, and that's for CAPD. It is a permanent external catheter. So I didn't mention, though, but with the catheter, once that's placed and it heals up, you can swim in the ocean and you can swim in a chlorinated pool. We really would like you to stay out of a lake, a river, a hot tub, those type of things. There is something called a pre-sternal catheter, which actually is higher up in the chest. If you have to be in a hot tub, if you're one of those people that just loves the hot tub, the surgeon can put in a pre-sternal catheter. Like I said, that's higher up on the chest, and it's quite different from a central catheter that we talked about for hemodialysis. But it is up higher, so you would be able to sit in a hot tub. But we really, kind of really frown upon that, because what you want to remember, what bacteria need to thrive is warmth, darkness, and moisture. So the 3 ingredients to brew an infection are in a hot tub or a lake or a river. So we really kind of frown on that. But we do tell patients, if you do any of the, if you get your exit site wet in a not so great condition, if you do go in a hot tub, what we recommend is as soon as you go out, we want you to do exit site care. So exit site care really can be done every day in the shower, or it can be done separately. So we don't want you cleaning your exit site with your washcloth that you wash the rest of your body. We'll give you supplies, sterile 2x2 and some soap, and we want you to clean around that exit site. And every day you're going to look at that exit site. That's your lifeline, right? So we're going to look for signs of redness, warmth, any kind of drainage, and we'll show you how to secure that exit site so the catheter is not moving around, pulling on that exit site. There's actually different types of belts. There's Velcro belts. There's mesh belts. Some people just tuck them in their underwear, but different ways to secure that catheter. So we did talk about some risk of infection. So we talked about the risk of infection from the exit site. We talked about the risk of infection from not doing the procedure properly, if you wouldn't wear a mask or if you didn't have good hand cleaning. Also, there's the potential to gain weight. So we did talk about there's dextrose in the bags, and there are 3 different strengths of dextrose. We like to see people use the weakest strength of dextrose to be able to pull the fluid and the toxins, but so everyone knows that diabetes is one of the major causes of kidney failure. So with our diabetic patients, if their blood sugars are not very well controlled, they may have to use a stronger strength of dextrose in order to pull the fluid. And then now that's where the weight gain comes from. So if you use a lot more, stronger strength of dextrose, certainly it would be like eating sugar, right? So because you would be putting that sugar into your system. So we really try and help people out, hope they have an endocrinologist that can help them. Now, some people really with a 1.5 or the lowest strength of dextrose, they see no change in their blood sugar. When they test their blood sugars, they see no change. Some people it does affect, some people it doesn't. So it kind of all depends on how your body, works with your blood sugar. We also talked about the storage of supplies at home. They do have to be inside. We don't want them outside. They can't freeze. You don't want them in your garage. And then the body image changes. So actually some people really could not imagine having a catheter, they'll say sticking out of their body, and, but it's, it's all about your choice and what you want. And so, like I said, if you decided that you wanted to start with peritoneal dialysis and for whatever reason you didn't like it, you could always have the choice to switch to hemodialysis either at home or hemodialysis in the clinic. So here's our talking about home hemodialysis. So there are several ways to do home hemodialysis. There is conventional, and that's using the big machine like you see in your dialysis clinic, right? And with the conventional machine, you do have the option of doing more than 3 treatments each week. So you have to remember that's actually a benefit. So when your kidneys work, they work 24 hours a day, 7 days a week. The more dialysis that you can get, you have to remember you're going to be healthier, your heart's going to feel better, you know, you're not going to be stretching out that heart muscle and your veins and your arteries holding on to all that fluid. So conventional machine may need some plumbing and electrical work done to the house, and typically the big dialysis companies will have a conventional machine installed in your house one time. If you decide then that you want to move or you want to move the machine somewhere else, then it would be at your cost. Usually, home hemodialysis training typically takes from 4 to 6 weeks. There's a lot more involved with home hemodialysis training than there is with peritoneal dialysis training. So you'll learn infection control, just like peritoneal dialysis, but you'll also learn how to mix dialysate, and that is the solution that we use for hemodialysis. You'll learn cannulation techniques, so that's the needle placement in the access. You'll learn emergency procedures, and with home hemodialysis, it is usually mandatory that you have a care partner with you. As anyone knows who has done hemodialysis, there are side effects from hemodialysis that may require you to have someone available to help you. So alone, if you think about just the needles, you know, bleeding at the exit site, if you pull too much fluid off, you know, you may have an issue there. So you want to have somebody there that will make everything stable for you, and just in case you need anything while you're on the dialysis machine. There is an opportunity for nocturnal dialysis. So nocturnal is overnight, and actually there's nocturnal in-center dialysis as well that I did not mention. And some clinics that, you know, there's not a lot of clinics that do offer nocturnal in-center dialysis, but it is a good option if you want to do hemodialysis for a longer period of time and you have no support person at home, right? So nocturnal in-center dialysis actually is an 8-hour treatment, typically done 3 days a week. It's done overnight in a clinic, so the staff is there. They take care of you. But even if you're in-center dialysis, I really recommend that you're an advocate. So know the machine, know what the numbers mean. Know what it looks like. You know, when you go into a dialysis center, you should be walking past the sink. You should be washing that access off. You should know, you know, what your weight is. You know, how much fluid have you put on? What is your dry weight, right? So your dry weight is what you should weigh without excess fluid on. And that's actually a doctor's order. So your doctor will say, you know, your dry weight, and a lot of times, and you know, it's in the metric. So it might be 84 kilos or 170 pounds. And so you should know, you know, how much fluid you're putting on between treatments. Typically, it's not recommended to put more than 2 to 3 kilos, so that's close to 6 pounds, from 4 to 6 pounds on between treatments. And then over the weekend, you have that extra day there too, so you have to be really careful. But nocturnal in-center dialysis is a good option. Like I said, the more dialysis that you get, the better you feel, the you know, more stable your chemistries are, the better controlled your fluid is. So you should, you know, if you're interested in hemodialysis in a longer treatment than just the 4 hours in center, you should look to see if there's a nocturnal program in your area. But back to home hemodialysis, there is what we call short daily treatments. Now, they can be done on the conventional machine as well, but typically when you hear of short daily treatments, you think of the NxStage machine. So the NxStage machine is a portable hemodialysis machine that typically people run on 5 days a week or even 6 days a week for 2 to 3 hours. Now, depending on your weight, on your type of access, and how your blood flow will run during the treatment is what determines how long or short your treatment is. But like I said, if you think about with short daily dialysis, you're pulling that fluids off, you're pulling the toxins off every day versus 3 days a week. So everything's more stable. Chemistries are stable. your fluid control is much better, and your the opportunity to have a less restricted diet comes into effect as well. But you do require to have a care partner there with you for emergency situations. Same thing with home dialysis. Home hemodialysis, you would want to have a fistula or graft. So here's actually a picture of the next stage machine, and that little box underneath there is actually the water storage where you make your dialysate. You can see the dialyzer up there on the upper right-hand side, or left-hand side. It is portable. So when you go on vacation, you actually just take that top piece with you, the white piece with the handle there. It weighs about 72 pounds, but it does have a roll case, and it does travel for free. It is medical equipment. We've had patients take the next stage machine on cruises, camping, just all kind of crazy stories, and it's, just 2 or 3 hours out of their day. They feel good. They're getting that dialysis every day or 5 or 6 days a week. We have people that work full-time jobs. They come home. They may watch 2 hours worth of news. They pop themselves on, or their care partner pops them on the next stage. They get their dialysis, and they're living their lives, right? So what we see with these patients, though, is improved blood pressure control and fluid management. And we did talk about requiring a partner. Plumbing and electrical upgrades are actually not needed for next stage. The only thing you really need for the next stage machine is a drain and a fluid source or a water source. And actually, it doesn't have to be right beside the sink, if that's what you're thinking. They have lots of tubes. We have a plumber come into the house and kind of run tubing either underneath the floor or under the wall or whatever, so it's not all over. But, it's a really nice setup. And it's a good opportunity for people to do more frequent, short hemodialysis and be able to travel and live their lives. So with the next stage, if you get up in the morning and you feel like that's when you want to do your dialysis, you do it, or in the evening, at night, whatever works for you. So you're not constrained by a clinic schedule in order to do your dialysis. And then with hemodialysis or home hemodialysis, the requirement is actually that you only come to the clinic once a month, right? So you come in the clinic once a month with all your treatment records. You come to see the nephrologist, dietitian, and you actually will draw your own labs and send them in because you have access to your blood. Now that is with peritoneal dialysis, there's no blood access, so that's why those patients have to come in twice a month so we can actually draw their blood. But with home hemodialysis, you don't need to do that. You just draw your blood, send it in, it gets into the clinic. We're able to review your labs and determine that, if you're getting adequate dialysis or if any changes need to be done with your prescription. Okay, so transplant, we talked earlier about transplant. So we said that it is the golden option, but you do need to remember that transplant is an option. It is not a cure, right? And it is not for everyone. What you have to remember is transplant is a major surgery, and then there are anti-rejection medications that you must take for the life of the kidney. They have some side effects, sometimes not as bad as they used to be. I can remember years ago when people would get a transplant and they would be on a lot of high doses of steroids and be all swollen and puffy. They wore masks for months and months and months. They couldn't go around anyone, and we don't really see that anymore. Transplant has come a long way and is still coming. So there's a lot of great opportunities for transplants, and there's been a lot of changes. So now if you get on a transplant list, there's a great opportunity, depending on where you live, that you may be transplanted, typically from 2 to 10 years, depending, like I said, where you live. So what a transplant is, it takes the place of your kidneys, and it's actually placed in the front. It's not, they don't take your old kidneys out, usually, because that would be another surgery. And so you want to avoid any risk of infection, and any surgery would be a risk of infection. Sometimes, though, with polycystic kidney disease, the kidneys get real big, and then there's not a lot of room that kind of, cramps up the new kidneys, so they may take those kidneys out if they need to. So a successful transplant is the closest to having your own kidneys. You feel healthier and you have more energy. And a lot of times people can actually get a transplant before they need to start dialysis. So that's a really good option. Dialysis, hemo, or PD, they're both really good options for renal replacement therapy. But if you are healthy enough to undergo major surgery and you can get a kidney transplant, it is much more healthier for your body to have a transplant. But like I said, everyone is not a candidate for a transplant. Any type of risks associated with major surgery, infection, up to death. Certainly you have to have a good heart to undergo major surgery. There is a risk of a rejection, so there's no guarantee. But I'll tell you a lot, so years ago you would hear about rejections, and you don't really hear much of that anymore because, if you take your medications and they have to be taken every day, typically you'll go for your visits and they're always testing and looking out for signs of rejection. So they kind of intervene before that rejection comes into play. And so you have to remember, too, that you will be susceptible to infections and illness because what the anti-rejection medications do is they actually knock down your immune system so your kidney is not rejected by your body. So you actually can get on more than one transplant list, and I encourage people to do so if they're in an area where they can easily get to these locations. So where I am, I'm in Delaware, so we have Transplant Center in Delaware, and so we're associated with the PA. So if you go under UNOS, United Network of Organ Sharing, you can see how the networks are divided. So Delaware and PA are kind of in one network. So I encourage my patients to get on either Delaware or PA and then go down to Maryland as well, and get on that list as well. It doesn't make sense to get on more than one list within your network, but if you can get on more than one list, that's other opportunities. But you do have to remember that's where the follow-up comes in. So if you get a kidney, say, in a 45-minute drive, that would be, I would drive 45 minutes for a kidney, but, some people might want to consider if they don't have transportation, really only, limit yourself to what you're able to do. Wow. Okay, and so then the last option I want to talk about, like we talked about earlier, is the option for non-treatment. So you always have the right to refuse or end your treatment at any time. And so it is a hard decision, and it's best made with help from others that can give you perspective. If you decide to refuse or end your treatment, your doctor can refer you and your family to hospice for additional end-of-life support. If you're thinking of refusing or ending your treatment, you may want to speak with your spouse or other family members, your social worker, or a counselor as you make this decision. It's common for people with kidney failure to be depressed at times, and depression can affect the way you view your situation. So your doctor or social worker could help you work to decide if you're depressed. There are effective ways to treat depression, and once you feel better, you may see the options in a more positive light. So a lot of times when I do the treatment options sessions with the CKD patients, when they come to me, they're, thinking they're at death's door and, dialysis is just an alleyway to death. But really, we have a great opportunity. There's many, many options, for everybody to get educated on chronic kidney disease, the causes, how to slow down the progression. Is a big opportunity for us. So people that are on the call or people that we should really be spreading the word and educating as many people as we possibly can on kidney disease. And, if it comes down to it and you have to make a decision, really, be educated on all the options. And I just want people to know that the options are your choice. So you may have a physician that necessarily doesn't agree that, say, peritoneal dialysis is a good option for you. But you know what, if peritoneal dialysis is something, and as long as you don't have any contraindications, any surgeries that may have, cause a problem with peritoneal dialysis, you should really pursue what it is that you want to do. You do have a right to do that. And while I have everybody on here, I kind of just want to remind everybody that, we actually went to Washington for a couple of the bills, the Senate Bill 598 and the House Bill 1130 to be introduced to Congress for co-sponsorship. And what they are related to is for dialysis patients to be able to enroll in Medicare Advantage. and also to help with research for CKD, and then also for funding to not be limited for our dialysis patients. So kind of, get out there and talk to your government officials and make sure that they co-sponsor our bills for our dialysis patients. And that is about all I have. Does anybody have any questions?
Remember, for questions, you just have to push *6 or #6 to unmute your line. I know we did have some comments in the Q&A and chat on sort of how to manage peritoneal dialysis as a diabetic. I know you touched on that briefly, but I know some of the people on the call are a little worried, are hesitant to think about peritoneal dialysis because they are diabetic. Do you have any suggestions for those kinds of patients?
So I can tell you that at my clinic, I have over 105 peritoneal dialysis patients, and 60% of them are diabetic. And so really we encourage, those patients to really watch their blood sugars and keep their blood sugars under control. Like I said, if you do a good job with your blood sugars, that the low amount of dextrose that we can use in the solution really will not affect your blood sugar at all. But if it does, that's why they make the extra stronger solutions, and we would guide you through that. So your dialysis or your home dialysis nurse really would help you out. So part of what you do, or part of what we have our patients do every day that are doing peritoneal dialysis, is they get weighed, and we teach them to do an assessment. So you're going to look for fluid, right? You're going to take your blood pressure, and these are all signs that we can tell if you're building up fluid, right? So if you weigh more, if your blood pressure is higher, we can tell that fluid's building up. So then we would instruct you on how to use a different strength of solution, and we're not permanently, but we would tell you, do a couple exchanges with this stronger strength solution and pull that fluid off. But we would really, keep an eye on you, and we would guide you all the way through. That's the one thing that if you have access to a good home dialysis program, you're going to have a nurse who's going to develop a relationship with you, and you'll be really well cared for. But certainly you will be educated on everything to look for, when to call, what to do, so for our diabetic patients, we're looking at their blood sugars, we're looking at their feet, we do recommend that they go to an endocrinologist if need be. And even sometimes I've had patients that we put insulin, or that we teach them how to put insulin in the bag if they have to use a stronger strength dextrose, or if they find that their blood sugars are spiking or dropping, or so we're educated on all those things. But anything specific for any diabetic patients have any specific questions, or? No.
I had excuse me, this is John. I had a question about educating dialysis patients on getting transplant, getting donors.
Yes. So
is anything
what's
being
your
done
question?
proactively about that? Because I don't see that being done in a lot of dialysis centers.
So for you to actively look for donors, is that what you mean?
Yeah, to be encouraged and work with a social worker to identify and educate donors so they are aware. They don't have to be a match, and things like that.
Right. Yeah, you know what, John, that is true. There are a lot of people out there, but I'll tell you, so in the home dialysis clinic, actually where I work, people are very creative. We have people that advertise in their church bulletin. We have people that, there's a monthly free advertising magazine. It's called the Penny Saver. Some of our patients advertise that they're looking for kidneys there. Actually the transplant center that I work with, they created these little cards, and on the card it actually says, give the gift of life. So they tell you when you go to a church event or a party, you give out these cards, and what the card says, are you interested in kidney donation? And then gives you a website to go to, and then actually on the back of the card, it says this gift would be for, and it would be the kidney recipient's name. But really, you know, it's a difficult conversation, and I talk to my patients a lot about this, you know, to ask for a kidney, you know, or if a child wants to, you know, offer their kidney, you know, so it just depending on how close, you know, families are and having that conversation. Some people don't like to have that conversation, but, you know, the squeaky wheel gets oiled, John. So, you know, that's the truth. So if you tell people, hey, you know,
developed in a non-clinical setting to do just that, because sometimes the patients themselves do not want you to talk to their family members. And
that's correct.
What I've proposed is having a social worker or a coordinator on a weekend, have a potluck, have the caregiver invite their friends, and then take care of the misunderstandings and let them do what they want to do, because most of them don't know about that, and sometimes the kidney patient is waiting for a deceased kidney which may not ever come, and they don't realize the danger in waiting.
Right, that is the truth. That is the truth. So, yeah, just, I mean, we really need to be more proactive out there, you know, just let people know I'm in need of a kidney, and you know it's not near what it used to be. That it doesn't have. I mean, the blood type should be, but there's actually extended criteria. There's different kidney lists. There's, you know, different opportunities. You know, you might not get the perfect kidney that's going to last forever, but certainly if you have an opportunity to come off of dialysis for 3, 4, 5 years, I would take that chance, and I would take that kidney. But you know, people need to, you know, really be out there. But I guess actually, it's interesting that a lot of people don't even think about being on the transplant list. You know,
Yes,
and that's it's a great option. I mean, it's actually the healthiest option for people.
All right.
Hi, can you hear me?
I can hear you.
Hi, it's Lillian from Long Island, New York. My husband is a dialysis patient. I became a DPC to try and help people learn about everything you just spoke about. What I wanted to say is that I did find my husband a living donor being tested right now through a site called matchingdonors.com, and she's quite young. So I don't know if that would help everybody, but I've been sharing that with a lot of people.
Beautiful. That's excellent.
Yeah, we were, I wrote to Christy, and I told her that Channel 12 News happened to be in the diner that we go to every week with dialysis, because I come to every session, and they interviewed us. The owner told them about what we're doing, and that my husband's a dialysis patient, he's diabetic, and they gave us some airtime, so I'm hoping they air it. And I spoke about DPC, I spoke about dialysis, and also the matchingdonors.com. So you can go on the internet and just find it. They're in Massachusetts, and they're legit, because I checked them out, and they have a doctor who's the director of the program. So
Beautiful. Good luck. Good luck.
thank you. Thank you.
Yeah, exciting. Yeah, I just think, you know, we need to be creative. Get out there and start, you know, knocking on the doors or whatever, you know, whatever you have to do. You know, if you really want to get a transplant, let people know. You know, you're looking forward to that. You know, get on more than one list.
We are. We're also on a couple of lists.
Great.
Okay, well, thank you all for joining. Like I mentioned, if you have any questions to mind after the fact, feel free to let me know or let Joanne know.